Indian Society of Organ Transplantation, conducted here at Grand Hyatt Bolgati, Kochi. I take this opportunity to extend my gratitude to the brains behind this event. Dr. Jay Prakash, President Isot, Dr. Vivek Kute, Secretary Isot, Dr. Narayan Prasad, Treasurer Isot, Dr. Abhi Abraham M, Organizing Chairman, Dr. Rajesh R. Nair, Organizing Secretary, Dr. Maman M. John, Treasurer. Without further delay, let's start off with today's session. Post-transplant dilemmas, graft dysfunction. Please note, each session will be 10 minutes of speech and 3 minutes of discussion, after which a buzzer will be heard. I request all the speakers of today to keep the time. We shall now begin with the first topic. The chairpersons for the session are Dr. Shaji Ponnambathil, Senior Consultant Surgeon, Department of GI, HPB and Transplant Surgery. Dr. Malini Eapen, Clinical Additional Professor, Department of Pathology, Amrita Institute of Medical Sciences, Cochin. Dr. Murali Appukutan, Consultant Gastro HPB and Liver Transplant Surgeon at Medical College, Kottayam. The chairpersons will be the same for the consecutive 2 topics. The first topic is Early Allograft Dysfunction, Definition and Outcome in the Context of Live Donor Liver Transplant. The speaker for the topic is Dr. Vinendra Pamecha, Additional Professor, Liver Transplant and Hepatopancreaticobiliary Surgery at Institute of Liver and Biliary Sciences. I request Dr. Murali Appukutan to please introduce Dr. Vinendra Pamecha. Sir, please.
My immense pleasure to introduce my teacher, my mentor, Dr. Vinendra Pamecha, sir, to this talk. So I will be talking on early allograft dysfunction in LTLT setting. He is the lead surgeon, professor and HOD of the Department of HPB and Liver Transplant Surgery at Institute of Liver and Biliary Sciences, which is the largest public sector hospital in India, doing the maximum number of liver transplants with results at par with international standards, sir. And I welcome you, sir, to this wonderful talk. Sir, please, over to you, sir.
So, first of all, thank you very much. Thanks, ISOT, Professor Sudhi, and the team for having me here. Thanks, Murli, for the kind introduction as well. So, what I'm going to do is I'm going to talk on early allograft dysfunction in the context of live donor liver transplantation. So, just going through about allograft dysfunction. Graft dysfunction is defined as in the absence of vascular, biliary, immunological, infectious, or technical complication. So we can have a primary non-function that is within first week. It's about, the incidence is about 1 to 5%. It is more common in DDLT setting rather than in LDLT setting. We rarely see a primary non-function in live donor liver transplantation. Then what is more commonly seen nowadays is early allograft dysfunction. It is not clear. It may be up to 3 to 6 months. The incidence is about 10 to 30%, and if this happens, the graft loss can be up to 10 to 25%. And then there is late graft dysfunction. That is when the graft dysfunction is beyond 3 to 6 months. So the implication is the survival is inferior than those with adequate graft function. There is prolonged hospital course, so it is resource incentive when you develop when somebody develops graft dysfunction, especially early graft dysfunction. And it is important to identify this early because then you can prevent complication and also you can decide about retransplantation in those situations. So just comparing early allograft dysfunction in DDLT versus live donor liver transplantation. So in DDLT, we all know that there is a prolonged cold ischemia time and a long warm ischemia time as well. And nowadays, a lot of marginal livers are also being used. And then there is an ischemia reperfusion injury. So in that situation, the implications are very different, and the manifestation of early graft dysfunctions are also very different. Whereas in live donor liver transplantation, again, it's a partial graft where there is a graft, there is a portal perfusion. Then liver has to regenerate because it's a small graft. It has to regenerate in order to meet the metabolic demand of the recipient. And it is a more technically more complex procedure. And this is more susceptible to infections as well. The manifestation of early graft dysfunction in this setting are quite different from what we see in cadaveric liver transplantation. So just to, what are the factors which play in a live donor liver transplantation? So it's a functional hepatic mass which is dependent on graft graft to body weight ratio and an actual graft weight. And again, the quality of graft becomes important in terms of steatosis, in terms of other parenchymal changes as well. Then the one factor is graft hemodynamics, that is total inflow and outflow, which are very important in the context of a partial graft. And then recipient metabolic demand, that is the pre-transplant MELD status and the post-operative complication as well. And then all other factors like warm schema time, cold schema time, sepsis, rejection, vascular issues, biliary issues, and center experience. They are all actually plays a part in terms of outcome from the partial liver graft. So traditionally, it has been mainly about the size and total inflow in a partial liver graft. But actually, over the time, people have realized that it's not just about the size and total hyperperfusion, but there are lots of other factors which plays a part in terms of good graft function, and all these factors can contribute to early allograft dysfunction. So what is the spectrum of early allograft dysfunction? So it can manifest as a mild hepatic dysfunction leading to isolated hyperbilirubinemia. And if this process goes on, then it can lead to prolonged cholestasis, ascites formation, coagulopathy, septic complication leading to renal and pulmonary failure. And then if the patient develops multi-organ failure, then the only way to survive is to do a retransplantation. So coming to how to define, this is the main question, how to define early allograft dysfunction in the context. And these are the definitions which are put on here in the table, which are commonly being used. The first one was the Althoff one, which has become very common, and it was derived from the cadaveric setting, which is a bilirubin of more than 10, or an iron ore of more than 1.6, or AST80 of more than 2000 on day 7. So this was derived from nearly 300 patients, and it included all causes of mortality, all causes of early graft dysfunction. So it included the biliary, vascular, and infectious as well. And then 23% of this satisfied this definition. And so in the ones who satisfy the definition, only 13 of those died at 6 months. So the overall positive predictive value was around 18%. Then in 2016, the same definition was used in live donor liver transplantation, the same parameters, leaving behind the AST and ALT. In a larger number of patients, this is A2all data, 610 patients, and again it included all causes of mortality. 110 satisfied this definition, and 27 of this died at 3 months. So the positive predictive value was around 24%. Then Kumar again in 2018 modified this and basically joined the bilirubin and INR component at day 7, and again included all causes of mortality, and 22 patients satisfied this definition, and 13 of them died at 6 months. So the positive predictive value increased when bilirubin and INR was combined, so it was around 60%. Then Ikagami actually derived a definition in LDLT with a bilirubin of more than 20 at day 7, and for continuous 7 days after post-operative day 7 in 203 patients. It only included the patient who had mortality because of early graft dysfunction. So all the patients who had vascular or biliary issues were actually excluded from it. And then 22 of this satisfied and 13 died. Again, the positive predictive value was around 60%. So the problems with this definition are, most of this definition have been derived from cadaverous setting and they've been taken into live donor liver setting, include all causes of mortality. Only Ikagami's definition excludes the patient with other causes of mortality. And then they take a single day parameter and does not have a dynamicity. And all those who satisfy the criteria may not have a poor prognosis. So we are left in middle where lots of patients will actually satisfy the criteria for early graft dysfunction, but we don't really know who are those who are not going to make it good and may at some stage need a retransplantation. And if we can predict this early on, then actually we can prevent the complications as well and also decide about retransplantation. So what we tried to do was we tried to see our own data and see what are the predictors of early graft dysfunction and whether these definitions which are there in the literature, which can be applied to our data and how they do fare in our setting. So this was the data of 470 patients from nearly around 8 years or so. So we excluded the pediatric and adult ALFs and we only included the adult CLD patient. Again, we excluded the patient with vascular or atypical grafts or biliary complication or patient who had ACR and AMR as well. And we also excluded the patient who had mortality because of other causes like cardiac respiratory failure, intracranial bleed, or primary non-function as well. So the final study population was around 300 patients. And out of this, the EJD related mortality was in 19 patients, that was 6.2%. Okay. So this is just to show the causes of mortality in this. So the overall survival is 92.3% in this group of patients with an EJD related mortality of 19. So and the other causes of mortality were excluded from that. So we compared the variables between the patient with and without EGD related mortality, and this is the preoperative data in this patient. So the only factor which we found was significant was donor age. Donor age, higher the donor age was associated with more EGD related mortality. We didn't find anything significant in terms of more mild sodium or child's category, comorbidity, or even the difference between ALF and CLD and ACLF as well. Then the intraoperative parameters, we actually found a significant difference between the graft weight, actual graft weight, rather than GRWR. So GRWR actually didn't predicted mortality related to early allograft dysfunction in this group of patients. The other parameters like warm ischemia time, cold ischemia time were also not significant as well. In post-operative parameters, again, the ones who didn't do well had a higher INR, higher lower platelets, higher urea, bilirubin as well, higher AST, larger duration of ascitic drainage, developed more incidences of severe sepsis, and obviously they had a higher, longer hospital stay, ICU stay as well, and transfer to ICU as well. And the overall grade 3 morbidity was also higher in those patients. So this is just to show that the impact of GRWR, because LDLT most of the time we think for small size, but GRWR actually didn't influence the mortality related to early graft dysfunction. Then again, to distribute furthermore in GRWR, then because we had quite a few significant number of patients who had a GRWR of less than 0.8, which is considered to be a cutoff to define as a small for size. And again, we use quite a few smaller grafts as well. It was only when the graft size goes below 0.6 that influenced the mortality. Otherwise, the mortality was not influenced by GRWR. Then again, graft type, because we use quite a lot of left lobe graft as well, and the left lobe graft also did not influence the mortality as well. So what we did was we validated the available definitions in the literature on our own data set. And what we found was, although Althoff's definition was quite sensitive, but the specificity was low and the positive predictive value was also low as well. It was same with the A2R definition which was applied. Again, there was low specificity and low positive predictive value. And the Okumara definition, again, the sensitivity was quite low, although the specificity increased when the bilirubin and INR are combined. But again, the positive predictive value was low as well. Then economic definition, again, the sensitivity was low, but with a very high specificity. So all these definitions have their own issues and problems. And then we thought that we should try and derive what are the factors and whether we can come up with a better equation. So we looked at we did a multivariate analysis to look at the various factors. So this, as I said, donor age, graft weight, INR, bilirubin, and blood urea were the significant factors predictive of early graft dysfunction. And because we all know that the graft dysfunction cannot be derived from a single day definition. because sepsis is so common, and once you develop sepsis, hyperbilirubinemia is very common. But most of the patients who develop sepsis because of hyperbilirubinemia, they will start showing a downward trend in a day, in within 5 days time. So if that is persistent, then it should be considered as early graft dysfunction, which is a sort of not related to other causes of graft dysfunction. So we derived the definition in the way that we considered for 5 consecutive days bilirubin, INR, and urea. And basically that was, yeah. I'll just take another minute or so. So when we combine in isolation also bilirubin, INR, and urea predicted the early graft dysfunction with a very good specificity but still the positive predictive value was low. But when we combine bilirubin and INR, then both sensitivity, specificity, and positive predictive value increases. But when we combine urea as well along with that, then there is a good specificity with a very good positive predictive value as well. So this is basically bilirubin, INR, and urea. So bilirubin of more than 10, INR more than 1.6, and urea of more than 10 for 5 consecutive days. And it has got a better predictive value in defining early graft dysfunction. So this is the total population of 304, out of which 19 had an early graft dysfunction. Okay. And this is just to show the comparison with the other available definitions in the literature. And you can see if we compare it, so we had 19 mortality based on early graft dysfunction, and the definition EJD, LDLT actually had a very good sensitivity along with specificity of 99% and a very good positive predictive value and a negative predictive value as well. So this is the ROC curve. This is based on Althoff's definition. This is based on Ikegami's definition, which is 0.60. This is Okumura's definition, again 0.58. And when we apply our definition, the ROC curve was 0.86. So the take home from my side is an optimal definition with acceptable sensitivity, specificity, and positive predictive value is lacking in live donor liver transplantation. EJD LDLT definition, which is based on combination of bilirubin of more than 10, INR of more than 1.6, and urea of more than 100 for 5 consecutive days after day 7, has a better sensitivity, specificity, positive predictive value, negative predictive value, and a better area under curve. GRWR and MELD sodium have no significance in causing graft loss due to EGD. Donor age and absolute graft weight were predictive mortality related to EGD. Thank you very much. Thanks for your patience listening.
So wonderful presentation, sir. The topic is open for discussion.
Yes, sir. That was a very good attempt to define EJV in our cities, and mainly Indian population. We are doing LDLT mainly. So I have two queries for you. One, why exactly we used urea instead of creatinine? In most of the MELDs for everything, for all the prognostication, we use creatinine. Why in this study the urea was taken into account? And another thing is, all the patients you included were patients who died. Were there any patients who improved with early graft dysfunction? And have you included them also in this group? Or will it change the whole result of your study?
So coming to the second question first. So there were 19 patients who actually satisfied this definition. Not all of them. What we were trying to see was whether the patient, who are the patients who died because of EJD. So we wanted to know exactly, because as I said in the start, there will be lots of patients who will satisfy a definition. But what we really want to know, who are the patients actually who don't make it, and whether identifying those group of patients early on, and then we can have an opportunity of offering retransplantation. Because you know that retransplantation in a live donor setting is a very difficult task. Okay, it's not an easy thing to find another donor and to consider, console the family about retransplantation. But we all know that early allograft dysfunction does happen. and it's not like it won't happen. It happens, okay? And the literature is very clear in LDLT, 30% of patient, 25 to 30% of patient will develop early graft dysfunction. So the idea here was to identify that group of patients who have a very high risk of mortality because of early graft dysfunction. Primarily that particular thing. No, I'm not talking about vascular, biliary, and those issues. So if we can identify those early with these parameters, then we can actually consider for better optimization of those patients, and then consider maybe for transplant. The second question, the first question you have quoted about was creatinine and urea. So it was not we considered urea. Urea was one which came up as a parameter in identifying patient with early graft dysfunction on multivariate analysis. So multivariate analysis, which included all the factors, it included creatinine as well, but urea came out as a significant factor. So it was a surprise for us as well. But we all know that that whenever a patient is not doing well, and they will have high urias. Those who see a lot of this patient, and we all know that they will have high urias, and urea somehow is associated with liver disease. Joy is here, so he can also comment that how urea is associated with liver disease. So impaired liver function does lead to high urea because of the abnormalities with the urea cycle. So blood urea and nitrogen does rises with liver disease. Okay, so this was a surprise factor for us. And when we amalgamated urea with the blood bilirubin and INR, the positive predictive value actually increased up to 98%. That's what it makes the definition very strong.
Thank you. Thank you.
Thank you, sir. So the next topic is steroid refractory ACR or AMR definition, diagnosis and management. The speaker for the topic is Dr. Rachel Brown, Consultant in Cellular Pathology, University Hospital, Birmingham, NHS Foundation Trust. I request Dr. Malini Epen to please introduce Dr. Rachel Brown. Ma'am, please.
Thank you. So Dr. Rachel Brown is no new face among us pathologists, but since this happens to be an extended fraternity, I take this privilege to introduce her and hope to do justice to her resume. Dr. Brown is a consultant pathologist at the University Hospitals, Birmingham, and has over 20 years of experience. She's had a laudable academic career with many feathers of accolades and honors in her cap. Her areas of interest are liver, transplant, head and neck pathology, and she's been actively involved in research, published in many an index journal, and authored book chapters. She says that she chose pathology because it works to her strengths, and her advice to the young guns in this specialty is that you create a path niche for yourself amongst the clinicians so that you're part of the patient management and care. And to add a non-academic feather to her brimming cap, I'm sure Dr. Dinesh would love that, and Dr. Subindran would say, well, low connectivity is something that she cycles to work, and she's recently retired from hockey to be a triathlon athlete. The stage is all yours, Dr. Brown. Thank you.
Thank you very much for that kind invitation. I'm delighted to be with you this afternoon, as it is with you. It's the morning here. Okay, hopefully you can see my screen now. So here's the title that I've been kindly asked to speak about today. And I will try to do that justice. I'll set my timer in the short time available. I think it's really important at the beginning of this type of talk just to remember that, of course, there are many different complications that can occur in the liver allograft. I've listed them there, of which rejection is only one. Invariably, when the liver biopsy comes to us in pathology, the clinical question is reduced to rejection question mark. And of course, we need to think about the whole picture and potentially other complications. So it isn't always rejection, although that's what I'm going to speak about today. Rejection diagnosis, biopsy still is pivotal in that diagnosis. It's the only definitive way to confirm it. We recognize different types of rejection now. The Banff group helpfully summarised that in their update documents, the most recent of which now is 2016, but it is a very useful document, and the terminology that they suggest that we should attempt to use now, we should talk about T-cell mediated rejection and antibody-mediated rejection. There's also a variant of plasma cell-rich rejection, and we shouldn't be using that terminology of ACR, acute cellular rejection. It's hard to move away from it because it's so ingrained in our culture, but we should be trying to think a bit more mechanistically. So if we T-cell mediated rejection, we can see it at various time points post-transplant, usually early after the transplantation in the first 6 months. And there's a classic triad that's recognized histologically. I'll show you in a moment. If you're looking at T-cell mediated rejection later post-transplant, it can have slightly different histological features. It looks a little bit more chronic hepatitis-like. Here's the classic rejection triad. So PV is portal vein, and there is endothelitis of that portal vein. The block arrow is pointing to a damaged bile duct, and in the rectangle there's some eosinophils. So that would have been an example of a typical example of early, early post-transplant rejection, T-cell mediated rejection. If it occurs later post-transplant, the picture can be a little different. So in the left-hand panel, the lesion we're looking at there is central perivenulitis, inflammation and necrosis around the central vein. And the changes on the right-hand side in the portal tracts are a lot less impressive at first glance because there's fewer inflammatory cells, but when you look more closely in the top panel, there is damage to that bile duct, and in the lower panel, there's actually no bile duct at all. The bile duct is missing. So that is worrying for a progression now towards chronic rejection. So late post-transplant T-cell mediated rejection can look a little different. Once the diagnosis is made, we attempt to give severity. And we can do that numerically. I'm not a huge fan of numerical scores for biological variables, but nevertheless, we can use it as a rejection activity index, which denotes 1 to 3 for each of the parameters. In the later setting, and also in some of the other variants of rejection, it's actually very difficult to apply that system. That is just the grading criteria from the Banff document, just to say that it is there. So that usually responds, acute T-cell mediated rejection usually would respond to steroids. And I've been asked to consider today the unresponsive cases. The ones that don't respond to steroid, we worry because they may progress to chronic rejection. And things that can impact on that is how adherent the patient has been to their treatment. But in unresponsive cases, I think the first thing we should think about is the possibility of antibody-mediated rejection. So antibody-mediated rejection, the liver is more resistant to this type of rejection as compared to other solid organ transplants, and I've listed some of the reasons postulated why that might be. It's the target for the antibody-mediated rejection is antigens on endothelial cells. We have something in our armory, the C4D immunohistochemistry, which is well established and works very well in the heart and in the renal setting. I have to say, although it's presented very definitively in the Banff document, in practical terms, this is hard to apply in the liver. So we shouldn't rely on it. It's stable because it persists for longer in association with the endothelium. Important to recognize in the Banff criteria, you need compatible histology and C4D positivity, but you also must exclude other causes of graft dysfunction, and you also must see a donor-specific antibody. So we shouldn't think of this diagnosis as purely a histological diagnosis, because we often are not very good at establishing the diagnosis from that point of view, but this is a good example of how we need to approach the liver biopsy in a multidisciplinary manner and taking account of other measurements. So what are the histological features of AMR? This is how they're described: endothelial enlargement, a microvasculitis, you can see edema in the portal tracts, and quite often we see this phenomenon of extravasation of red cells, particularly into the hepatocyte plates. So these are the features that are postulated to mean AMR, they're not exclusive. So again, you need to take a global view of the biopsy and of the patient. I've illustrated some of those features here. So centrally, we've got prominent endothelium. Also notice that there is an eosinophils actually involved in the endothelitis process itself. That's meant to be a good indicator. In the top left, we've got microvasculitis. So you get this margination of inflammatory cells in small capillary vessels. And in the bottom right panel, nice linear staining with C4D. Of course, I've chosen a lovely example to share with you today. In practice, we rarely see that. It is not sensitive or specific in practical everyday terms, we have found. Here's another image showing the microvasculitis. Once you have your eye in for it, you see these marginated inflammatory cells in capillary-sized vessels. There is some slight damage to your bile duct here as well. And again, a microvasculitis. See, they're often rather monotonous appearing inflammatory cells, and they plug these small vessels. Here's another nice textbook example of C4D. Another feature that you can sometimes see and that it's easy to overlook is involvement of the artery. So we're very much used to looking at the portal veins, and now we look out for microvasculitis, but there's some lymphocytes in association with the intima of that little hepatic artery branch there. That may be another indicator. And here's a perivenular region and that extravasation of red cells that I was describing. When we see that as histopathologists, we'll say, how is the venous outflow obstruction from this graft? And usually the answer is no, we're not worried about that. And increasingly we feel this is likely to be a manifestation of endothelial damage in antibody-mediated rejection. So the Banff document presents this as very didactic and straightforward. I just say we don't routinely apply this system, I have to be honest, and the reality of it is much more complex and needs to be much more multidisciplinary. Important to note that both processes can occur together. So sometimes we might be looking at T-cell mediated and antibody mediated together. And we think of it particularly if the T-cell mediated process appears to be very severe. And so the pathologist, even if they don't see a good C4D, might already be starting to think about this and might include a comment in the report or in the multidisciplinary discussion that it's probably worth checking a donor-specific antibody in that individual. Very briefly, plasma cell-rich rejection may also be antibody-mediated. We feel it is dominated by plasma cells, obviously. And again, you can see it in a mixed pattern setting. I won't linger on that. There's just an example of it quickly. At low power, the inflammation is concentrated at the interface between the portal tract and the parenchyma, and it's rich in plasma cells. There's also a perivenular component that's rich in plasma cells. So my conclusions, I make it 9 minutes 20, I've been speaking. Acute rejection, so we should attempt to classify it now according to those Banff criteria, even though, as I've mentioned in day-to-day, it is not straightforward, but I think it is important for us to attempt to do that. Think about the mechanism. Is it T-cell mediated or is it antibody mediated, rather than just using that generic term of acute cellular rejection. It is difficult, as I've mentioned. So unresponsive or steroid-resistant acute rejection, think of AMR. If you have a rejection episode that isn't responding to steroid, because even if it did include an element of AMR, it would usually be expected to respond to the steroid. But if it doesn't, if it persists, then we really need to consider AMR, and then the treatment strategies might be different with plasma exchange and so on. And also the other thing to remember, as I mentioned at the beginning of the talk, if you have got an episode of rejection that is steroid unresponsive, maybe it's another complication affecting the allograft that isn't immunologically mediated in any sense. So we need to remember that there are other complications affecting the allograft, and the biopsy can help to pin those down sometimes. That's all I have. Thank you very much for your attention.
Thank you.
Thank you, Dr. Brown. You really stuck to the time, I must say.
The same watch I use for running. Yes.
Good, great to know that. Is Dr. Dinesh around?
Yeah, Malini, I am here.
Can we do the case and then take
Yes,
the
Malini, I
questions?
agree with that. Yeah, in the interest of time, we'll present the
Yeah.
case. Thank you, Dr. Brown, for sharing your thoughts on this. We are going to present a clinical case, and then as it unfolds, we will ask the hepatologist and the pathologist some questions, and we'll take it forward from there. Dr. Shweta Malik is my colleague, and she's going to start the case. So over to Shweta.
Good afternoon, everyone. I'd like to welcome our panel members first. Let's move on to the next session, which is a case study on steroid refractory rejection. The panelists for the session are Dr. Charles Panakel. He is a highly experienced gastroenterologist and is an expert in hepatology and liver transplantation, Aster Medicity, Cochin. Dr. Joy Varghese, Director of Hepatology and Transplant Hepatology at Glen Eagles Global Health City, Chennai. Dr. Dharmesh Kapoor, Senior Consultant Hepatologist in Yashoda Hospital, Alexander Road, Secunderabad. Dr. Malini Eapen, Clinical Additional Professor, Department of Pathology, Amrita Institute of Medical Sciences, Cochin. The moderators are Dr. Shweta Malik, Assistant Professor General GI Surgery, AIMS Cochin, and Dr. Dinesh Balakrishnan, Associate Professor, GI Surgery, AIMS Cochin. Over to you.